Great. So, Julian, by the way, that was a great talk. So, and concerned I learned something well disturbing about myself along the way. No, just in any case, that was a great, actually, wonderful talk. Mine's probably going to be completely 180 in a different kind of talk, which will show that you, in private practice, which I'm in, you don't need intellect. So I don't need the intellectual freedom necessary. But in any case, as I said, my name is David Antezana, and I'll start talk by asking the question, there we go. Why are we here? Well, there's no cosmic, not meant to be a cosmic question or a spiritual religious one. That's Sistine Chapel there in Rome there. It's more just a simple one. And, back when I was here, I kind of look out and as you're just correct, it's 1989 seems a long time ago for, I'm sure, a lot of you. Maybe some of you may or may not have been born, I don't know. But I remember very well what it was like to be your age. And I think the old picture that I have, which I wanted to put up here that I still have, that one that you just had taken was outside, a little cooler day. The makeup probably looked about the same. But since we just moved in this last year, it's hanging out under a bunch of pictures that I probably still have to get to. But for some of you, many of you, looking from past to present, how we got, the question is, so how did I get here? Could many of you, one path that you might take? Well, I was born and raised, high school and college, all inside city limits. I went to a little Benedictine monk school that most of you never heard of, St. Anselm's. But still, you keep the old ties. I went down the street to Catholic University of America, the alma mater of Joe Gibbs, actually. I'm proud to say he got his bachelor's, his master's, and his PhD all at Catholic University. And one of the reasons, probably the only reason, he actually took me into his lab. But I spent 2 wonderful summers, starting in '89, with Dr. Gibbs. And I think one of the beautiful things about the NIH, which many of you will see, is like St. Anselm's, it was probably the last, I've been used to being surrounded by people that are a lot smarter than I am my entire life, and that includes my career. But really, here at NIH with Dr. Gibbs' lab and with also with the monks at St. Anselm's, being surrounded by such intelligent people that really can make you feel like you want to drive and do more, and who are so benign towards you and your presence there and wanting to help you. That will go on as life goes on, but I don't think you might find it as ubiquitous when you move on a little further in life. And so on, I made my way to University of Minnesota before coming back closer to home to Johns Hopkins, then running off to the Oregon Clinic. So one of the things I should thank all of you also, mentioned to inviting me. My mom wanted to say thank you for inviting me because it means I got to come over and stay with her for a day after living so far away in Portland. So now, one of the things that I did while I was in the summer program, I wasn't in the surgical neurology branch myself. I was in the laboratory central nervous system studies. And what most of you would not remember Kuru, but you might remember mad cow disease. And one of the things that we studied in that lab and that I was involved in was a characterization of prions, protonation infectious particles that play a part in what we call the transmissible spongiform encephalopathies. These are Kuru, Creutzfeldt-Jakob disease, bovine spongiform encephalopathy, the mad cow disease that many of you have heard of, and finally scrapie. Now, Kuru was pretty fascinating stuff, actually. It was more of an anthropologic type study as much as anything else. Dr. Gadjusak, working out in the field in conjunction with Dr. Gibbs here, went out to see the 4 people in New Guinea. So you pull out your map and you look around Australia, they're up there, and you'll find New Guinea. Particularly in Papua New Guinea, there were 4 people were there, F-O-R-E. And they had this interesting disease, this degenerative neurologic disorder, where they just started having all sorts of walking like drunken sailors, shaking, and they find, why is that? Well, they had one very interesting thing about them. When their ancestors would die, the 4 people would consume them through cannibalism, essentially. And they would eat their brains. And it was felt that this was the cause for the transmission So the cannibalism stopped, and so did Kuru. We know Kuru probably a bit more, what better known as Creutzfeldt-Jakob disease, CJD. For those who are in the neuro world, it actually is important because it happens to about 1 in a million people. And when there's a suspected CJD patient that's being biopsied, the room gets shut down, every instrument essentially gets thrown away. That's a big deal. But it's become better known to us to be as BSE, mad cow disease, and specifically I said scrapie, which is seen in sheep and rats. And sheep would go up against the fence and scrape themselves so hard that their wool would come off. And that's why it became known as scrapie. Now, the interesting thing about this is an idea that maybe at this time you're all used to, but the thought that something could be transmitted with no evidence of nucleic acid, no DNA, no RNA, not the way that bacteria, fungi, protozoa, viruses all have some form of nucleic acid, and these do not. And what it was found is that these are essentially proteins that seem normal to our body. They're not. They think of them as our normal proteins that have developed an abnormal method of folding that can induce folding amongst other proteins. Still not fully understood, but essentially a transmissible disease with no nucleic acid that's still extremely unique in the armamentarium of infectious diseases. So interesting, as a matter of fact, that it's earned at least a couple of people Nobel Prizes. And one of them, indeed, was Dr. Gibbs's partner, Dr. Gajdusek. Now, these are some of my early mentors. I bring them up because it's very important to sort of get this started now, to recognize who your mentors were. And mentor, by the way, is capital letters there, actually. And that is it's a proper word. It's a name, just a little history. The name mentor was actually a person, a friend of Odysseus back in the Greek classics who helped take care of his son. Not surprisingly, the word has gone on to mean that someone who helps you, someone who imparts knowledge to you, perhaps wisdom. Levon Parker up there in the middle is the man that Cedar Reed here was actually he was actually the man who coordinated the summer program. Very much championed everyone coming in, and with the emphasis on underrepresented communities. He worked also closely with Dr. Gibbs, and Dr. Gibbs was a wonderful man who really, I don't think that I'd be anywhere where I am right now without him and the manner in which he helped me. But as time went on, I went on to Minnesota, and that's Fernando Torres down there, and upper left-hand corner, Rafael Tamargo and Dr. Kostok, who were at Johns Hopkins. Just a little thing to remember him. He started out as a young biologist, getting his bachelor's from the University of Maryland Eastern Shore. And after becoming an administrator, stayed on for 42 years as a director of summer programs, finding time to mentor hundreds of students and being a U.S. Army and Air Force veteran as well. Dr. Joe Gibbs was, when I was here, the deputy chief and eventually the chief of the Laboratory of Central Nervous System Studies. As I mentioned, studying Kuru and being the man who showed that CJD was transmissible between primates, earning Dr. Gajdusek the Nobel Prize for Medicine in 1976. He himself was a very serious man about his career. He was a Navy captain, serving in World War II from 43 to 46. Spent 40 years in the reserve, and to say he mentored hundreds of students, probably a bit of an understatement, as a matter of fact. He was very prolific that way. Dr. Torres himself took me under his wing in Minnesota, and I worked in the EEG lab for a couple of years, studying transcortical magnetic stimulation. Before MRI, before CT, there was a time that many have forgotten, but EEG was actually used very great deal, and he pioneered the study of pediatric trauma in EEG and headed up the EEG lab where I worked for my first 2 years in med school. Eventually coming back closer to home, spent 8 years in Baltimore doing my residency, and in 2 of those years spent some time doing neurovascular research fellowship with Dr. Tamargo, working on an inflammation and stroke in a rat middle cerebral artery occlusion model. And one of the beautiful things I had to show for 2 years was a miserable allergy to the rats. They're even more painful than some of the PTSD I have from all the Western blots that we did here to all that time. So, and the one thing I did that was a little unusual is after a period of time, I always had my peripheral vision always kind of seemed focused on what Dr. Acoustic was doing. I'd come in, and as neurosurgeons back then, we weren't used to seeing, and nowhere on a neurosurgeon's agenda or operative schedule would you ever see a T4 to S1 fusion. You didn't see that in the early 90s. It didn't happen, and I found myself interested, but really there wasn't any way to talk to him because neurosurgeons didn't do orthopedic spinal deformity fellowships in those days. So I made a few friends in the orthopedic department. One of them was a wonderful man by the name of Cam Huckle, and he went to talk to Dr. Acoustic, who gruffly told me he did accept from applications from neurosurgeons. He'd just never taken one before. And after a quick and gruff interview, he was kind enough to take me because I just couldn't bear the thought that I would graduate without knowing how to do what seemed to be that interesting surgery. As time went on, it was a bit unusual. I think I'm probably one of the first 10 neurosurgeons who ever did an orthopedic spinal deformity fellowship. And now it's pretty commonplace, but it's one of those things where when you meet people, you find mentors, and you make sure that you continue, quote, neural networking, or networking, the case may be. You'll be surprised at the opportunities that'll open up for you, perhaps one that you didn't even think about. And then finally, another area that I was interested in was stereotactic radiosurgery, and this developed into a practice with Gamma Knife, and thus leading me to one of the areas that I want to discuss. I called it neurosurgical hybrids because, as you heard earlier from the wonderful discussions from the previous your previous speakers here, that neurosurgery in and of itself doesn't exist in a vacuum. No part of medicine does. But one of the things that can happen is, for example, as a neurosurgeon, you take a walk into the world of, quote, endovascular work, often thought of as the area or the playground of the radiologist or cardiologist in heart, and not only become expert in the area, but become the expert. And one of the things that hadn't been done very much, neurosurgery and orthopedic surgery, existed very separately. That doesn't happen so much these days, and that really has only been relatively recent. Not unlike the neurovascular surgeons who are capable of doing both the endovascular procedures and the open procedures. There just aren't very many of them. And now, as we have more and more people who can do this, there just still aren't a lot of us who are a bit on the older side that have spent a lot of time training in both areas. And what it does lead to is a hybriding, once again, sort of cross-fertilization of different disciplines being able to speak with each other and coming to understand each other, where perhaps there may have been some animosity before. And there certainly was in the Scoliosis Research Society, which I'll touch on later. Those walls get broken down. And it leads us to be able to spend more time doing complex procedures with adult spinal deformity, spinal tumors that might also lead to difficult and deforming spines, which can be corrected. And finally, bringing in more neurophysiology into it, the intraoperative neurophysiologic monitoring, where you actually can monitor somatosensory evoked potentials, motor evoked potentials, as well as direct stimulation of nerves, in order to be able to see and monitor exactly what's going on during a procedure and see if you have to make clinical changes surgically at the time. Additionally, finally, there's radiation oncology. They found that indeed they just bought something called a Gamma Knife, stereotactic radiosurgery, not really surgery per se, but what it did lead to is an ability to be able to work with radiation oncologists. An opportunity came up to go to the Karolinska Institute, where Lars Lexells and others had worked over in Sweden to add to this technique and learn this particular brand of it. And so I moved on to that area. So let me show you a couple of things that we do. A 45-year-old female presented with scoliosis during was diagnosed with scoliosis during childhood. Never really did much. It wasn't particularly bad, but as time went on, it progressed. She'd failed all conservative forms of non-operative treatment, chiropractic treatment, physical therapy. She'd even gone off to naturopaths. That's very common in Oregon, by the way. The upper Northwest, there's just naturopaths just everywhere, and they certainly have a role to play, but well, let me just move on from that. So she presented to me with severe progression of leg pain and significant L3-4 radiculopathy to the anterior thighs. In regular English, what that means is the lumbar nerve roots, L3 and 4, like many others, have what we call dermatomes, areas that they govern. And the front of the thighs over here, even down to the knee, and even below, can be L3 and or L4 type of pain when the nerves are getting squeezed or affected. And so she presented for surgery. It was a touch of a general, she was a generously proportioned lady, and so required a little bit of weight loss before we would operate on her. So she lost 30 pounds so that we could do what I felt best at the time was a combined anterior posterior approach to her spine. And so here we go. This is how she presented, and this is the lumbar curve that she had that was, at this point, progressing. It was contributing to her back pain. But in the adult, unlike kids, okay, in the adult deformity population, leg pain is really one of the big reasons, and nerve root compression, why people end up having surgery and why they have significant pain. And so by taking off the compression, we straightened out the spine, and she's doing much better. This is what she looked like from the side, and we were able to maintain the appropriate lumbar lordosis and thoracic kyphosis. Stereotactic radiosurgery, which is fun because I don't actually have to operate. I put a frame on a head, I can have an espresso, a cup of coffee, and do a little bit of planning, but I get to work with the radiation oncologists and physicists, which also allows me, once more, additional cross-fertilization to understand what someone else is thinking, their approach to a disease process that we acquire. And what it does, stereotactic radiosurgery is sort of not unlike taking a magnifying glass on a hot summer day, focusing on a leaf and burning a little hole in there and then stopping. And the surrounding areas, as the gamma rays that come from the radioactive come through the target and then disperse, they just burn that area. And this is done by placing a helmet on someone's head, literally putting the screws to them at 4 locations. We use lidocaine, by the way, just so you know, to kind of numb the pain a bit. XYZ coordinates. It's very straightforward. Put someone in an MRI, then you put them in the machine, and by programming someone with this type of apparatus on their head, you get down to sub-millimeter accuracy of being able to treat someone at the skull base. Very simple, very straightforward concepts that took a great deal of complex programming and money to put into effect. And this is a bit more of a picture of what the cobalt looks like itself, the collimators that are used in order to treat a patient. Here are some real life cases. An acoustic neuroma, which is a tumor of the skull base and cerebellopontine angle. If you draw a line straight in from your external auditory canal and one just off the midline to the same side, where those lines intersect is where you'll find this tumor coming off the 8th cranial nerve, and often people present with hearing loss, miserable tinnitus. Before, almost the entire time, you'd have to undergo an open procedure, which would be quite successful, but quite painful, and unfortunately, more often than we'd care to say, would leave you with a 7th nerve deficit, meaning your face would look like this, and you wouldn't speak very well either. Unfortunately, that could be very, very significant and debilitating. No one likes looking like that or sounding like that, do they, after all? Now, the thing is, if you took the best surgeons on the planet, highly, highly skilled surgeons, and you had them do the open procedure, well, they could get you pretty much the same results you get with Gamma Knife. But this, frank reality means there's a lot more people that can get treated by those of us who may not be so skilled at the skull base, perhaps. In any case, what it does deliver is very solid results. Without having to open someone's head, they come in the morning, they're gone by lunch. Something else you can do is treat trigeminal neuralgia, facial pain that can be so severe that people commit suicide as a result of the pain, something that's very well known in neurological and neurosurgical circles. You can take these patients and with an approximately 80% success rate, treat them in the same manner without having to perform a similar procedure as you would with the tumor to go in and basically rough up the 5th nerve and take any vascular vessel, any artery that may be on it causing it. Triggers would include significant talking, chewing, showering, and brushing your teeth itself could cause this pain. People would lose significant weight, become malnourished, and withdraw from society oftentimes as a result of their pain. And this is similar treatment, a few slices up. Here's the fifth nerve, it's a few millimeters away, but from where the eighth nerve would be, but for the purposes of neurosurgery, it might as well be a mile. One of the things I've been able to do, despite the fact that it's private practice, if you think one of the things I've been able to do is actually, fortunately, be involved in NIH studies here through Johns Hopkins because of the time I spent there. With spinal deformity, I've used some of the work that I did with Dr. Kostwick to be able to look at some of their complications and outcomes they were doing in a relatively burgeoning field where complication rates, even amongst most competent surgeons, can be 25 to 35%, very severe. Finally, with Gamma Knife, we're doing case studies. And so this has been an interesting to be able to do. I won't focus on it much other than to tell you that the reality is, even in private practice, if you take the time and take time out, yes, you have to cut out a few surgeries and take some of your resources and pay people like these wonderful people that help me, that you can actually do some work. And it is fascinating and wonderful to stay intellectually stimulated throughout your career. And every now and then you do have to take a step back when you've been doing something for the same way for a while and say, how do I want my life to be different? How do I want things to move forward? So there's Jennifer on the left, who's my assistant, who makes certain that, well, basically she runs my life outside of the house. Christine, immediately there, who's my research assistant, and without her, I wouldn't have been able to get any of this off the ground. And the newest member, Dr. Baker, Doctor of Nurse Practitioners, they have that now. I did not know that, but she applied, and she makes certain that I get back, if I've been a little tardy in getting back to my patients so they don't want to shoot me, I get back to people and has kept me on track, fortunately. Finally, what is your future going to bring? Well, for me, I've been fortunate enough to be admitted into the Scoliosis Research Society as an active fellow after many years as a candidate. And we neurosurgeons are not the largest group in there yet, but we're working on it. And as I go and evolve the team, yours, well, it can be like this. The world is your oyster. It's a little pearl in there or something. But I think you've heard it. I won't try and be too redundant. Everyone here has told you that, your life can be pretty much anything you want it to be. You have enough time to learn about, well, some of the limitations that life can bring and the realities, but what's most important really are our family, as Dr. Meeks brought up really quite nicely, and your friends, and just having a good way of looking at life. So, Amasua Amaruya Amaquela is Quechua. My family hails from Bolivia, and our blood background stretches back to the Incas. And this is a language I knew how to speak when I was about 5 years old, and I'd visit Bolivia, and my parents would let me run amok on the farm, thinking that I'd learned Spanish from everyone around there, and they'd forgotten that on the farm, back in those days in Bolivia, no one spoke Spanish. They all spoke Quechua. So I'd come back to DC after the summers, and I wouldn't want to speak English or Spanish, and 2 days before school started, all I wanted to do was speak Quechua. But since I've forgotten it. But the thing is, study hard, and I think if I can leave you with anything is that, remember, what is it that gets you where you are? Well, you're all smart. You're all smart, or else you wouldn't be here. One thing I learned is that in one way is in this life, just having a good, strong work ethic, just being nice to people, and smiling as often as you can, even when it hurts, has gotten me a lot further in my life than my intellect ever has. And so remember, especially for those I want to bring up, remember that you're represented, underrepresented part of the community. And for all of you, that others will start looking for you for guidance a lot younger than you may be comfortable with it. And thus you will need wisdom. So remember who will be your mentors. For me, there were people from Father Peter all the way up to John Kostwick, who will be the ones that you will look to develop some of this wisdom that you will need to someday be able to come back and give good advice to younger people who want it and need it. Here's a view that we have in Portland. If you're ever interested in coming out to visit in Oregon, I'm pleased and proud to say that we have many views like this in Oregon. So come on out anytime, and I can tell you the view from the top up there is even better than the view from below. Thank you. I hope I didn't run too much over.
Any questions? All right, one quick question.
Right, so there is an ideal size, actually. So tumors generally are, in general, we would prefer that tumors be 3 centimeters or smaller in order to treat. We can treat even multiple tumors, multiple metastatic tumors at the same time, but depending on the location, you do have to be careful about the cumulative effects of how many areas you're treating. And if there are some structures such as the optic nerve, which are extremely sensitive, can only tolerate so much radiation, and you may be limited in your ability to be able to perform the procedure in those cases. But we are also doing tremors even, for example, in certain situations, and we certainly treat vascular lesions as well, some vascular selected lesions.